Today, I will be presenting on crisis intervention for suicidality and homicidality using a trauma-informed, ethical, and community-based, specifically in Nebraska, framework. This topic is especially important in clinical practice because decisions made during crisis situations can have both immediate and long-term consequences for client safety. For that reason, evidence-based and system-informed approaches are essential. By the end of this presentation, participants will be able to identify evidence-based suicide prevention and response models, apply trauma-informed crisis principles, understand how trauma is assessed during crisis, explain mandated reporting responsibilities, and identify trauma modalities that are appropriate for clients presenting with suicidal or homicidal risk. Rather than covering everything about suicidality and homicidality, this presentation really just focuses on clinically essential and actionable strategies. So, scope of the problem. National data from the CDC indicate that suicide remains one of the leading causes of death in the United States. And this rate is ever growing, as you can see from the graphic on some statistics. In addition, recent meta-analytic research by Akbar and colleagues in 2023 found that PTSD is strongly associated with increased risk of not only suicidal ideation, um, but suicide attempts and death by suicide as well. Clinicians must also assess homicidal ideation and violent risk. Research shows that trauma exposure, especially adverse childhood experiences, or ACEs for short, is associated with increased risk for both self-directed and outward-directed aggression. And because of this, crisis intervention must address safety and stabilization while also considering trauma history and systemic context that came before. There are several evidence-based suicide prevention models supported by current research. David Jobs in 2021 describes the Collaborative Assessment and Management of Suicidality, or CAMS for short, as a collaborative framework between clinician and client, treating suicidality as the primary clinical focus rather than a symptom. A 2021 analysis by Nuige and colleagues found that structured safety planning interventions significantly reduce suicide attempts compared to usual care. What this means is that safety comes first, and without that intervention, clients are more likely to attempt suicide. At more of a systemic level, SAMHSA's 2022 988 framework emphasizes integrated crisis response. So services work together instead of in isolation. Continuity of care, meaning crisis response doesn't stop when the client leaves or when the call ends. There is always a follow-up, and reduced reliance on law enforcement as well. It is important to distinguish safety planning from no harm contracts because they are very different. Safety planning is an active clinical intervention that is collaborative, personalized, and evidence-based. It includes things like identifying the client's warning signs, internal coping strategies, social supports, and means of safety. No harm contracts, on the other hand, are basically just asking the client to promise they won't harm themselves or others. Norwegian colleagues' 2021 meta-analysis found that safety planning type interventions are associated with reductions in suicidal behavior. In contrast, the no harm contracts lack that empirical support, and they do not reduce suicide or homicide risk and may even create a false sense of security. for clinicians. For this reason, current best practices strongly discourage the use of no harm contracts in crisis settings. Now, moving on to trauma-informed care. Uh, Trauma-informed care is grounded in five core principles: safety, trustworthiness, choice, collaboration, and empowerment. According to SAMHSA's Trauma-Informed Care Guidelines published in 2020, these principles help reduce re-traumatization, improve engagement during crisis, and really just help the client feel respected and supported during acute crisis. Trauma-informed care ultimately reframes crisis behavior as an adaptive response to overwhelming experiences rather than pathology. So basically, rather than asking, "What is wrong with you?" trauma-informed care asks, "What happened to you for you to respond in this way?" In a 2020 review, Pirtle and colleagues concluded that trauma-informed approaches ultimately improve engagement and public mental health outcomes. In crisis settings, this means focusing on emotional stabilization before deeper processing. Crisis intervention operates across multiple levels of care. According to SAMHSA's 2022 framework, at the local level, this includes emergency departments and mobile crisis teams. At the state level, responses include involuntary commitment procedures when necessary. At the national level, the 988 Suicide and Crisis Lifeline provides 24/7 access to trained counselors who can assess risk, provide de-escalation, and connect individuals to local services. According to SAMHSA 2022, 988 was designed to expand access to immediate crisis support and reduce reliance on law enforcement only responses. Additionally, there is a crisis text line where individuals can text home to 741-741, offering an additional low barrier option if you're not comfortable calling. So now I want to give kind of a dive into response systems specifically in Nebraska. So in Nebraska, crisis services are coordinated through regional behavioral health systems overseen by the Nebraska Department of Health and Human Services, or DHHS for short. At the local level in Northeast Nebraska, crisis response often begins with emergency departments such as hospital-based behavioral health services or referrals to regional mental health providers. At the state level, Nebraska has centralized crisis access through the Nebraska Family Helpline, which provides 24/7 screening, crisis assessment, referrals, really just serving as a single entry point into the state's behavioral health system. Going even further at the national level, Nebraska DHHS confirms that 988 connects callers to local crisis centers within the state, providing immediate access to trained crisis counselors, which we mentioned earlier. This layered approach really allows clinicians to coordinate care across systems and work together, whether that be emergency, regional, or even statewide. So to illustrate how this system works in practice, this brief clip from SAMHSA explains what exactly happens when someone calls 988. So really, as the video describes, 988 connects individuals to trained counselors to assess safety, provide de-escalation, and really just be there for someone. So during an acute crisis, trauma assessment should really focus on brief screening rather than asking the client to go into like detailed trauma narratives. Cloitre and colleagues in 2020 emphasize recognizing patterns of trauma-related symptoms, such as disassociation, heightened anxiety or hyperarousal, emotional numbness or avoidance. And all of these things are especially prominent in cases of PTSD. In other words, our priority during crisis is helping the client feel safe and grounded before exploring past trauma in depth. The goal in crisis is stabilization, not trauma processing right away. Research consistently shows a strong relationship between trauma and suicide risk, which we touched on a little bit before. Understanding this relationship prevents oversimplified risk assessments and supports more comprehensive intervention planning. When assessing homicidal ideation, clinicians evaluate intent, plan, access to means, target, history of violence, substance use, and emotional regulation capacity. Unlike fleeting anger, homicidal risk becomes clinically significant when there is an identifiable intent, plan, and access to means, very similar to suicidal risk. Crisis settings can create opportunities for previously undisclosed abuse to surface. A 2025 systemic review of mandatory reporting research highlights that clinicians' ability to identify and report suspected child abuse or neglect really depends on their understanding of warning signs, reporting procedures, and barriers to reporting in diverse systems. Indicators to pay attention to include physical injury, emotional withdrawal, fear responses, inconsistent explanations, and behavioral changes. And while understanding that reporting systems themselves can present barriers and facilitators that influence outcomes. Mandatory reporting laws require clinicians to report suspected abuse or neglect regardless of client consent. However, research shows that barriers like confusion about criteria, lack of training, and systemic constraints can impact reporting accuracy and clinician confidence in reporting. And although reporting can feel like a rupture in trust for the therapeutic relationship, trauma-informed clinicians can explain the process clearly and really just support clients through it. Trauma-informed reporting involves explaining limits of confidentiality clearly, providing that emotional support, and maintaining that transparency throughout the entire process. Several trauma-informed modalities are effective for clients presenting with suicidality or homicidality. However, the first step should always be to prioritize that stabilization before trauma processing. Asarno and colleagues 2021 supports DBT for chronic suicidality, and Cloitre and colleagues note that trauma-focused CBT and motivational interviewing can also be useful. However, while modalities such as EMDR can also be helpful, they should only be introduced after safety and stabilization have been achieved. There are also important practices to avoid during acute crisis. As mentioned before, clinicians should avoid intensive trauma processing before safety and stabilization has occurred, but they should also avoid minimizing suicidal ideation or relying on unsupported interventions. Norwegian colleagues 2021 Meta-analysis reinforces that structured, evidence-based interventions are necessary to reduce risk effectively. Clinicians should also avoid dismissing any aggressive statements as just anger. Minimizing homicidal ideation can increase risk just as much as minimizing suicidal ideation. Hospitalization can be appropriate at times, but it should be paired with safety planning and continuity of care to reduce dropout and improve follow-up. We can't assume hospitalization alone resolves a crisis. Care has to be continuous and connected to follow-up supports. Ultimately, crisis intervention must emphasize stabilization, collaboration, and continuity of care. Now, I'd like you to think through this case as if you were the clinician on call. I also want you to notice that this case includes suicidality, aggressive ideation, substance use, trauma history, possible risk escalation, showing that crisis work requires simultaneous assessment of safety, trauma, legal responsibility, and systems coordination all at the same time. So just take a few minutes and read over the example case and kind of what they report. Okay, so now that you've read the case study, I would like you to take another few minutes to reflect on these questions in relation to that previous case study. Now that you've kind of written through the questions I'm asking you, I'll just go ahead and read them to you again while you're kind of thinking about that and reflecting on how you would answer these questions. What are your immediate safety priorities for this client? How would you apply trauma-informed principles in this interaction? How does this case raise mandated reporting concerns? Would hospitalization be appropriate? Or are there other alternatives you can think of that might be more appropriate? And what treatment modality would be appropriate after stabilization? This case really just illustrates how crisis intervention is never just about suicide risk alone. It requires integrated decision making, safety planning, trauma informed stabilization, evaluation of homicidal ideation, including assessing whether the client reflects emotional distress or actual intent, a plan, ethical judgment, and coordination with community resources. And lastly, I just want to throw in a little critical thinking question for you um, about how your response to these questions would differ if the client were a minor. So, in summary, effective crisis intervention prioritizes safety and stabilization, integrates trauma-informed principles, utilizes evidence-based prevention models, fulfills ethical and legal reporting responsibilities, coordinates care across community systems. Contemporary research from 2020 onward consistently supports structured, collaborative, and system-informed crisis intervention as the most effective approach to reducing harm and supporting recovery. And here are some references for you to consider.